I'm going to talk about menopause today. I have talked about menopause previously at one of these conferences. I cannot remember if it was last year or the year before, and I spent a lot of time on more of the conventional hormone therapy in terms of reviewing the results of the Women's Health Initiative and things like that. So I'm not going to do that this time. A lot of the feedback that we had, that I saw, was people were looking for alternative treatments. And so even though I'm going to run quickly through the conventional hormone therapies, I have tried to spend some time on the non-conventional, or I've broken it down into kind of the conventional FDA-approved alternatives to hormone therapies. I've tried to look at some of the integrative medicine, some alternative treatments, including herbal therapies, and then I will briefly mention bioidentical hormones, which I think is what people want to hear about. But if you have questions about the conventional hormone therapy, I'm happy to take those as well. So first, yesterday, just as we were trying to define the perimenopause, definition of menopause is actually a little bit easier, although it is retrospective, because it is 12 months of amenorrhea without any other obvious cause. So once you hit a year from your last menstrual period, you're menopause by definition. The average age, this is in the United States, is 51.4. About 5% of people go over the age of 55, and about 5% of people are between 40 and 45. Less than 40 years old is abnormal. That's when it becomes premature ovarian failure, and that's when you need more of an evaluation to find out what is potentially going on. If somebody doesn't have a uterus and you can't measure their last menstrual period, so if they don't have a uterus but they still have ovaries, diagnosis is by symptoms. If you need to get a diagnosis for some reason, and I'm not sure what that reason would be, because you are treating symptoms. So knowing you're in menopause, if you don't have any symptoms, I don't see any clinical utility to that. But if you want to do that anyway, an FSH greater than 25 is suggestive, although you should probably measure that on more than one occasion to make sure it stays elevated, because remember that slide yesterday where it kind of goes up and down and up and down. FSH greater than 70 is a little bit more definitive. So what are the problems of menopause? I'm going to break it down into menopausal symptoms, what we're good at. I think we're pretty good at treating hot flashes or hot flushes. I think we're pretty good at treating vaginal dryness and the vulvovaginal atrophy, which is now termed the genitourinary syndrome of menopause, because it includes all of not just the vulva and the vagina, but the bladder and the urethra and all those kind of symptoms, although I think still primarily the symptoms that we're seeing are vulvovaginal atrophy, usually related to the primary complaint of dyspareunia. What we're not good at, but women would really like us to be good at, especially speaking from a gynecologist point of view, weight gain is the number of also a very prominent complaint. Sleep disturbances, mood disorders, which I think we covered pretty well yesterday, low sexual desire, and all the sexual dysfunctions in general, as well as joint aches. The health consequences, osteoporosis and cardiovascular disease, we all know those increase in women tremendously after menopause, and we need to always think about those in terms of screening, prevention, and advice. And also the development of metabolic syndrome, which increases dramatically. And I'll go over some of the reasons why that may happen after menopause. I'm going to start talking with conventional hormone therapy. We'll talk about, again, the two major problems that we treat, which is hot flushes and vulvovaginal atrophy. Hot flushes occur about 75 to 80% of women who are going through menopause. The average duration is 4.9 years, but about 1/3 of people continue to have these symptoms for up to 10 years, and there's a unfortunate 8 to 9% of women who are still having hot flashes up to 20 years after menopause. So when you look at the recommendations for hormone therapy, which is don't use it beyond 5 years, there is probably, 33+% of people who you're really doing a disservice to if they're really symptomatic. Vulvovaginal atrophy, when you follow people prospectively, you can see how it increases. Unfortunately, vulvovaginal atrophy is a lifelong diagnosis. If you have it, it generally doesn't get better on its own, and it is usually progressive. And up to 50% of people who have vulvovaginal atrophy will be symptomatic with it, either because of dyspareunia or general vaginal dryness, irritation, discharge. So it's not only a sexual problem, and that's really important to remember. Sleep disturbances happen in up to 50%. Moodiness happens, we talked again yesterday, even though it's more likely in the perimenopause than postmenopause, it's still more common in postmenopause than premenopause. That was a lot of P's, and glad I didn't have anybody close so I didn't spit on anybody. Low sexual desire can be as many as 40%, although only about 10% of women say that this is causing distress. So remember, a sexual dysfunction is not a dysfunction unless it's causing stress. So if you ask somebody, are you having a desire, problems with sexual desire, and they say yes, your next sentence should be, is this causing a problem for you, your partner, your relationship? And the answer to that is no, then you cannot pursue that. It's only a problem if it's a problem for them. Joint aches can be up to 50%. Weight gain, I put 150% because I very rarely have people come in and say, I'm losing weight rapidly, what can I do? So let's start with some of the conventional hormone therapies. And again, I'm not spending a lot of time on this because I think most of us are probably a little familiar with them. Remember that for estrogen, you have both estrogen withdrawal, and estrogen withdrawal is about the first 2 to 5 years, and that's when you have most of your problems with the hot flushes, the sleeplessness, the palpitation, the mood problems. And then there's estrogen deficiency symptoms, which unfortunately are forever after, and that's the genitourinary syndrome of menopause or vulvovaginal atrophy. And it's probably estrogen deficiency also that is giving you those chronic, well, it is estrogen deficiency that's giving you those chronic problems of osteoporosis and cardiovascular disease. Progesterone, you're not really withdrawing from progesterone, and the only reason we use progesterone to add back is because of, again, endometrial protection. The FDA-approved indications for hormone therapy, by the way, it's now, when I gave this lecture last time, it had changed from hormone replacement therapy, or HRT, to hormone therapy, which was HT, and now it is menopausal hormone therapy, so now it's MHT. There's lots of committees somewhere, I'm not on any of them, but somewhere there's lots of committees. When there are no contraindications, so the FDA-approved indications are vasomotor symptoms, urogenital atrophy, and bone health maintenance. So this is more of prevention of osteoporosis, not treatment of osteoporosis, and that's only when it's not first line. It's only when there's a high-risk patient with no other treatments available. And again, if you diagnose with somebody with osteoporosis, it's acceptable if they can't take anything else, if they're within the proper age and criteria, to put them on hormone therapy, but technically you're not treating it as much as you're preventing progression. It's not FDA approved for any of those things that people want help with treatment. So how do we treat it? Vasomotor symptoms. Estrogen therapy will decrease hot flushes by 75 to 80%, which is really a tremendous decrease. It needs to be systemic. You can't use the vaginal estrogens to treat hot flushes unless you use the Femry, which is the one that has high enough doses that it's absorbed and it is systemic. You have to talk about risk versus benefit in all patients. Again, the biggest risks being of blood clot and breast cancer. In most women, the benefits are going to outweigh the risks. What I find most interesting on this slide is the treatment of estrogen decrease hot flushes by 75 to 80% versus 50% placebo. So there's a really large placebo effect for the treatment of hot flushes, and I speculate that's why so many of the over-the-counter products work so well, although we'll talk about some of those in a little bit. Dosing of estrogen, I have put this chart up there. I am one of those really bad with the metric system kind of person, so don't go for my doses up there. I didn't cut and paste this table. I actually typed it in, so I may have some of my zeros in the wrong place. The point of this is to remember that there are the standard doses that are the kind of that we grew up on, which was basically Premarin 0.625, S-trace 1 milligram, and then the transdermals at the various, usually about the 0.5 is where we would start. Just like birth control pills, doses get lower and lower, so you have the low dose ones, which again, you're looking at the 0.45 or 0.3. There are many brands, I'm just referencing Premarin. You go down to the 0.05, and the transdermals have drop doses. What I recommend and what I do in my office, I used to be able to rattle off every different hormone preparation there was with every dose and everything, but so few people will take hormone therapy anymore. It's really, we don't use it that often. I have a printed out list in my office that I keep for a reference for myself of all the different types of estrogen replacement, all the different doses, and I do the same thing with birth control pills. It's easy to have a quick reference. Again, we have great apps where we can look up individual drugs, but sometimes it's hard to get those lists, and that really helps you in decision making. The newest ones, which aren't all that new anymore, are the ultra low dose. That's like the Menostar, the 5L dots, and things like that. Those have variable efficacy, and they're not actually FDA approved for the indication of hot flushes. They are approved for osteoporosis, for the prevention of bone loss. So I generally don't start people who come to me with a lot of menopausal symptoms in terms of hot flushes. I don't start them on the ultra low dose. Where I use the ultra low dose are in that percentage of people who are 65, right? What's the WHI recommendations when you tease out the WHI? The risks are significantly different in women who start hormone therapy more than 10 years after menopause versus before 10 years. But I still get a lot of women who are more than 10 years after menopause who are having a fair number of symptoms, who want something for symptoms. Those are the women that I'll put on the ultra low dose. They're ultra low dose, they're patches. The transdermal ones, I think, have less risk. If somebody's coming to me with symptoms, again, the recommendation is the lowest dose for the shortest time. But I like to start with the more standard doses, especially if they're very symptomatic. If you're going to take estrogen, you might as well take enough to treat your symptoms. Is the risk between 0.45 and 0.625 so significantly different that it's worth having 6 hot flashes a day instead of 16? Probably not. So I like to start higher and then work lower. It's very easy to talk women into doing less. It's much harder to talk them into doing more, especially when women are so hesitant about hormone therapy. Even if they're not hesitant about hormone therapy, they go home and all their friends tell them that they should be off it because it's bad. Another population that I use the ultra low dose on frequently are all the poor women who were on hormone therapy, were happy as could be, and then all that WHI stuff came out in the news and all the doctors pulled them off of it, and they've been unhappy ever since. And they come to me and they're like, oh, if only somebody would give me estrogen back. And you talk about the pros and cons and risks, and obviously if they have a lot of coronary artery disease or heart disease, you're not going to do it because that's the biggest risk of the distance from menopause is the heart problem. But if not, it's a good place to turn to. Dosing of progestin, the natural micronized progesterone, which is 200 milligrams a day for 12 days a month or 100 milligrams daily. Medroxyprogesterone, which is Provera, the standard written dose is 2.5 milligrams daily or 10 milligrams a day for 12 days. I think that's a fairly high dose, and I don't ever give that much. I'll give, first of all, I hardly ever give cyclic, so I would be giving 2.5 milligrams a day. If I gave medroxyprogesterone, I much more often give the natural progesterone. But I usually give 2.5 a day, or I would do 10 milligrams a day probably for 7 days. If I was going to do 12 days, I probably would only do it every 2 or 3 months. And you can see how they bleed. If you have them on hormone therapy and you give them cyclic progesterone, and every time you give it to them, they bleed, that means they're building up a lining. But if you give it to them and they don't bleed, they're not building up a lining, and you're giving them endometrial protection. The thing to remember about natural micronized progesterone is that it's peanut oil. So it's very important to make sure you're not giving it to people with a peanut allergy. And that they know it's in peanut oil, so that if they have children around with peanut allergies, even though they should be keeping all their medications out of reach, that's especially important to know. The levonorgestrel, the Mirena IUD, has been used fairly commonly now as the progesterone for endometrial protection for peri and postmenopausal women. It doesn't have the FDA indication for that, but it, I think, has become standard of care enough that I think it's probably okay to use it, with the same caveat that when you initially put it in, there may be some abnormal bleeding, but after that 3 or 4 or 5 month period, if you're getting abnormal bleeding, you're going to have to evaluate the endometrium. Progestin-only treatments for vasomotor symptoms. Interestingly, the Cochrane review says that there is some evidence that progestin alone can treat hot flushes, but it's not recommended without concomitant estrogen therapy because of the unknown risk of breast cancer. Again, remember, in the Women's Health Initiative, on the estrogen-only arm, there was a decreased risk of breast cancer. On the estrogen-progestin arm was where you saw the increased risk. So you don't know if you want to give the progestin alone. And the next part of this, as you all recall from all my fondness for Depo-Provera yesterday, is the dose that they looked at, 500 milligrams IM of Depo-Provera on days 1, 14, and 28, which they compared to Effexor. It was more effective than Effexor, although I imagine all those women would have to have been also on Effexor. Or Megace, 40 milligrams daily for 6 weeks. Those are whopping doses of progesterone, and I would not be able to ever make myself give somebody that amount of progesterone. The upside of it was it offered up to 3 to 6 months of relief, and my guess is that's how long it took them to get out of the coma. There is one medication that is conjugated estrogen, 0.45, and the Vasodox, it's the New Jersey thing again, 20 milligrams a day. It's a selective estrogen receptor modulator. Its trade name is Duvi. I have not used it a lot. I don't know if you guys have a lot of experience with it, if you're seeing good things with it. The benefits is less breast tenderness, less of the progestin side effects, and it does provide endometrial protection because it's not insurance covered. The risk of it is blood clots, and my concern was always that, that SERMs increase blood clot risk and estrogens increase blood clot risk. So if you put them together, are we seeing an increased blood clot risk? And we've been reassured or assured by the people who have done the studies, and it doesn't look in the literature as though it's becoming an additive risk, but that is something you may want to mention just for full disclosure to your patients. Long-term breast data is not available. It's likely neutral, although it may actually be protective, and that'll kind of come out in the wash. Current dosing suggestion or recommendation for hormone therapy is to do a transdermal estradiol plus an oral micronized progesterone. Why is that the recommendation? Again, the transdermals have the least thromboembolic effect because they're avoiding the first pass through the liver. There's new data emerging showing that this is the best breast cancer profile in terms of the micronized progesterone. So again, we knew that the estrogen part was not as much the culprit as we may have thought, although it probably still is a little bit. But this is showing a little bit better benefit from the micronized progesterone. The other thing is micronized progesterone doesn't have as much effect on cholesterol because it does not lower your HDL cholesterol. So it has less of a cholesterol effect as well. Timing of hormone therapy for vasomotor symptoms, again, immediately after menopause or perimenopause if needed. Why? 3 good reasons. This is why the symptoms happen. You generally remember the average duration of the hot flushes is about 4.9 years. So if the recommendation is to not use estrogen past 5 years because of the increase in breast cancer risk, hopefully people won't need it for longer than that. And also because the initiation timing right after menopause is the most beneficial. It's still good and protective for cardiovascular disease if you start it within those first 5. Less so, but still beneficial if you start it within 10 years of menopause. Conventional non-hormonal therapies, the SSRIs and the SNRIs, clonidine, kind of our old favorite, gabapentin, and I think I also mentioned Lyrica, although I forget to put it on the top here. The SSRIs and the SNRIs, Effexor is only highlighted because it's the only SNRI up there. They have all been shown to be effective versus placebo for the treatment of hot flushes. Zoloft and Prozac have been shown not to be effective, so those shouldn't be your first choice. The only one that's FDA approved is Brisdel. Remember, Brisdel is the lower dose of Paxil, is 7.5. The problem with Brisdel, again, insurance very infrequently covers it, so I usually just prescribe 10 milligrams of Paxil if they're looking for that treatment for their vasomotor symptoms. We can try Brisdel. Some people, always want to do lower is better, and we can try it, but I tell them if insurance doesn't pay for it, it is probably not worth the money that they're going to spend for the prescription for that 2.5 milligrams a day. Fine-tuning, I think we talked about a lot of this yesterday. If you have depressive symptoms, low activity in addition to the hot flushes, your SNRIs may be a better choice than the SSRIs. Women with breast cancer on tamoxifen should not take either the Paxil or the Prozac because it may decrease the conversion of tamoxifen to its active metabolite. When you read this, it's a lot of theoreticals and maybes and perhaps and could be's, but I think because we do have alternatives, it's probably in your best interest and most importantly the patient's best interest to avoid these. If the symptoms don't improve on one of these drugs, try another one before you move on to a different class of drugs. Just like in depression, sometimes they're a little bit more effective. The other classes of drugs, gabapentin, Lyrica, clonidine. As a gynecologist, I use a lot of gabapentin and Lyrica, and I do that because probably right now, about 35% of my practice is vulvodynia and chronic pain. So I've used a lot of these drugs. If you're a more general, less kind of pain specialized gynecologist or a practitioner, you may not use a lot of these drugs and they seem kind of big and scary when you talk about them. Gabapentin is really, really well tolerated. But what I have learned is that when they talk about 300 milligrams 3 times a day, which is the most well-studied doses for hot flushes, although you have to be as high as 2,400 a day to be equal to the same amount of treatment as estrogen, start low. These drugs, the most common complaint I get from the gabapentin people is I feel loopy. It's kind of like squishy. I feel loopy. I just don't feel like myself. I usually start at 100 milligrams at night and titrate up. Once they get used to the loopy feeling, if they have it, I tell them to go up for another 100. I usually can get, I have to confess I don't use it a lot for hot flushes. My vulvodynia patients usually kind of peter out once they start hitting about 900. You can give up to 600. You could probably give up to 900 at one dose. I usually give 600 at one dose, and then I try to spread it a little bit more through the day. I always give them 100 milligram pills so that they can increase it, and they can also try it through different times of the day so that they can maximize the benefit and minimize the side effects. The side effects, again, headache, dizziness, that disorientation, or kind of that loopy feeling. Lyrica actually has a couple good studies where you can see these are the 2 different doses of Lyrica versus placebo. So you do have good improvement of hot flushes from Lyrica, but again, I want to point out that this is only over 6 weeks, and you can see even the placebo has a pretty good effect. But Lyrica, 75 twice a day or 150 twice a day. Clonidine, I haven't ever used a lot of clonidine because I was always afraid of lowering people's blood pressures, but again, after yesterday, I may start using some more clonidine. The transdermal therapeutic system is preferred, but it does have some significant side effects which can be limiting its use. Vulvovaginal atrophy, I'm not going to spend a lot of time on this. I've just listed all the different options, the creams, the tablets, the rings. What's exciting this year is that we now have UVAFEM, which is the generic for Vagifem. So hopefully we will get a little bit more insurance coverage of it. The other exciting thing this year is vaginal DHEA. Prasterone is finally FDA approved. We've been hearing about it at conferences for years. Their FDA approval came out in November. I have to admit, I was so excited about it. I've probably already written 10 prescriptions for it. Then I met with the drug rep the other day who said it's going to be in pharmacies like next week. I haven't heard back from people, so maybe the pharmacists are just holding on to the prescriptions. It's 6.5 milligrams of DHEA. What's really exciting to me about DHEA is it's a pro-hormone, so it metabolizes. It metabolizes into estrogens, it metabolizes into testosterones. Okay, so you're going to have, remember there's a lot of testosterone receptors, especially at the entrance of the vagina, so you're going to have a lot of good benefit from the testosterone. It's an insert that's used nightly. It's actually approved for moderate to severe dyspareunia and not just vulvovaginal atrophy. They are going to start pretty soon doing some studies for desire, which is interesting. It probably, vaginally, the studies have shown that it doesn't increase either your estradiol or your testosterone levels out of the postmenopausal range. But there is a small bump, and that small bump may be enough to boost desire. And they're going to start doing some studies on desire, which will be really great if we finally have something for desire. The one thing that, as I was sitting there, I kept thinking of all these things I didn't add into my lecture, but I should have. The one thing I'm going to mention about all of the vaginal products is our breast cancer population. Vaginal estrogens in breast cancer patients are still contraindicated. However, vaginal DHEA doesn't carry the label. It's not labeled as contraindicated in breast. Can you believe that? I can't believe it because they're saying it's non-hormonal, which doesn't make any sense because it's hormonal. So don't let that lack of a contraindication sway you. But in your breast cancer populations, depending on the type of tumor, the length of time from their diagnosis, a good discussion with them and their endocrinologist, you can prescribe some of these vaginal estrogens if everybody's in agreement. There's some difference between your breast cancer patients who are on tamoxifen versus the aromatase inhibitors. Tamoxifen, remember, blocks the receptor. So if somebody's on tamoxifen, it may be a little bit safer to give them some of these vaginal estrogens, whereas on the aromatase inhibitors, where they're working really by the lack of estrogen in the system, that tiny bump in estrogen may make a difference. There's not good scientific data behind that, but you should also, excuse me, include that in your discussions. Aspina, I don't think Aspina has done near as well as people thought it was going to be. Again, it's an oral SERM, 60 milligrams daily. Again, moderate to severe dyspareunia. The problem is the side effect is hot flushes, so people have to be well away from that part of their Menopause, the risk is clots. There's no endometrial stimulation, which is good. The long-term breast data, again, not available. At best, it's going to be preventative. At worst, it's going to be neutral. It's good in select patients. Again, I use it most often in my vulvodynia population who is not able to really put in any vaginal inserts. Conventional non-hormonal therapies, you know what we still have, the first line according to both ACOG and the North American Menopause Societies are lubricants, which you use with sexual activity, moisturizers on a regular basis. A couple little details to remember. Those with propylene glycol can cause cell toxicity and irritation, so you want to be careful. If you're not seeing improvement, change your lubricant. Petroleum-based increases your BV. Glycerin-containing can increase colonization with yeast, and the oil-based are not compatible with condoms. Neither are the petroleum-based. In your menopausal population, it's not a pregnancy issue, obviously, but it is an STI issue. As a gynecologist, I think it's or somebody caring for women, it's your moral obligation to go to your local drugstore at least once every 6 months and spend an hour or two in that aisle and look through all the different things that your patients are getting and using and not telling you about. I find it really interesting. My new favorite lubricant right now, I have to tell you, is something called Uberlube. And it's not because it's so fantastic. I just like the name. It's actually a silicone-based one. I always tell people it's great for when you want to have sex in the back of a cab. But their claim to fame is that in Sweden, where it's made, it's also the #1 hair care product. So if it doesn't work, I'm just saying. The other ones that are good, there's another two that I just want to bring up. Joe Premium, okay? I don't know, again, names are amazing to me. It's a very good silicone-based one, and if you look, most of them come with a different bases. The other thing that is a really good find is Key E, Key/E. I've not seen it in any stores, you have to get it online. It's a combination of coconut oil, palm oil, and vitamin E. And I have been using it, I've been recommending it, and I've been hearing really great things about it, except for one patient who said it really hurt. Laser therapies and radio frequency therapies, they are basically, I explain them, it's almost like dermabrasion of the vagina with the intent that it's going to stimulate healing, and with stimulated healing, you're going to get an increase in vascularity and an increase in thickening of the vaginal mucosa. I unfortunately don't have any personal experience with this because trying to get one of these machines into our university setting has been a nightmare, although we continue to try. It has reportedly very good outcomes. It is not FDA approved for this indication. All the other symptoms, this is where I wanted to spend some time too. Effects of hormone therapies on all the other symptoms that we hear about. Weight, neutral and negative, neutral, neutral, neutral. Sleep. If you're not sleeping because of hot flushes, then treating hot flushes will help sleep. So again, neutral or secondary. Mood, variable. There are some people who think it's a little bit preventative if you catch it earlier in the perimenopause. Again, variable. Sexual desire, we'll talk a little bit about. The benefits are usually secondary. Joint aches, this is the one that's interesting to me, is that there is some evidence that either estrogen alone or combined, probably secondary to the estrogen, that there is a little bit of improvement in joint aches. And that's a very frequent complaint. Again, it's off-label because it's not an FDA-approved reason, but it is certainly worth looking into. I'm going to talk about these all in a little more detail. So weight, just a couple facts, which is going to make all the women in the room cry a little bit. Pre-ovulatory eating is less than post-ovulatory eating when your estradiol is the highest. So when we lose our estrogen, we are tending to eat more. And everybody always thought it was the progesterone, but studies are saying it's the estrogen. Unfortunately, I think it's both, so there's no winning. Why? It's a central active mechanism of estrogens that increase the satiating potency of cholecystokinin. So estrogen makes us feel fuller, maybe because we're always bloated. Fact, estrogen withdrawal results in weight gain and visceral fat accumulation. Reason, it decreases our energy metabolism. So when we lose our estrogen, we lose our metabolism. Metabolic rate decreases by about 2% a decade, and I think probably a little bit more around menopause. Fact, functional brain imaging. So again, if you look centrally, you can see an effect of dopamine on our processing of flavor and our cognitive inhibition of eating. Why? They don't know, I just think because life is not fair. No other reason. So basically menopause works against us in every aspect there is in terms of weight. So you would think that giving us back estrogen would fix all those problems, but for some reason it does not. There has been a Cochrane review about estrogen or estrogen-progesterone combination. It had no impact on either increase or decreasing weight gain. Some of the DHEA BMI data show that there was weight gain in the placebo versus in the treatment patients. And also studies show that pre-menopausal weight is not predictive of postmenopausal weight gain. So even if you're thin before menopause, it doesn't mean you're going to stay thin after menopause. The biggest influence, unfortunately, is genetics, which we can't fix, and diet and exercise, which, as we know, everything always comes back to diet and exercise. Even though we want a quicker fix, that's probably what it comes down to. Sleep disturbances. Fact. Sleep breathing disorders increase after menopause, independent of aging or change of body habitus. So even if you're not gaining weight after menopause, you're increasing your sleep disorders. Reason unknown. Fact, menopause is associated with a significant reduction of melatonin levels. Very interesting. Reason unknown. Fact, even fixing the hot flashes does not relieve all the sleep disturbances in menopausal women. And the reason is because anxiety, depression, sleep apnea, restless legs are also becoming more common in this age group. So it may not be primarily a menopausal problem. So how do we treat sleep disturbances? Hormone therapy is always a good try if hot flushes you think are very contributory. We want to treat anxiety and depression. Refer for evaluation if you suspect that there are other sleep disturbances. Sleep therapies, cognitive behavioral therapy has been shown to be helpful for insomnia without the use of concomitant medications. So cognitive behavioral therapy is something to think about. Sleep stimulus control, I think somebody talked yesterday about sleep hygiene. Basic rules for a good night's sleep. Again, I took this up to date, which was surprising to me because I did not know my mother wrote for up to date, but apparently she does. And it's everything that your mom has been telling you, and we have been telling our kids forever about all the things that we should do at bedtime. So I think it's just important to go over these with your patients. They're obvious things, but as we all know from our interactions with everybody, patients, colleagues, everybody, common sense is not always common, and so sometimes we have to reinforce these things. Medications for sleep, I'm very hesitant to start giving medications for sleep. I definitely don't prescribe the benzodiazepines. I will not give Ambien unless it's for a very short course, somebody who's traveling, somebody who wants to get back on the right time zone, somebody who's in a death of a family, kind of then I will, but only small amounts for short times. Melatonin agonists, it's interesting. Since our melatonin levels are decreased, you would think that if we gave melatonin agonists that we would really improve insomnia. It doesn't work in all patients. And I think it's just like everything else, it's multifactorial. It's certainly worth a try. Doxepin. Doxepin 25 milligrams at night. I'll tell you a story about Doxepin, breaking every HIPAA rule in the book. My dad, who I inherited my anxiety from, Was always a very anxious guy, never slept. His anxiety was getting out of control. I was like, you have to go see your doctor, you have to get him put on something, and his doctor put him on doxepin. Now, doxepin is one of the older tricyclics. And when he put him on doxepin, I was like, why in the world would you put somebody on a tricyclic with all those potential side effects? And so I called the doctor and I said, listen, I don't usually do this. I don't want to be a pain in the butt, but I'm just curious why you picked doxepin. And he said, because it's sedating. He said, because some of the anticholinergics helps my patients not have to get up during the night and pee. And it also treats their anxiety. He said, so it treats their anxiety, so it does all three things. I have started using quite a lot of doxepin in my patients since that time, just at the 25 milligram dose. And I have to say, people love it. I did have one person come to me and say, what about that new data about the anticholinergic, the blocking the cholinergic effects with increasing the risk of dementia? I don't have an answer to that. There was some preliminary data about that, about some of the anticholinergic meds increasing your risk of dementia. I don't know how good that data is. If anybody could give me feedback, I'd be happy to take it. But I think 25 milligrams at night is probably not a huge significant dose that I would really worry too much about it, especially if it is helping people. There are lots of other sleep aids, and people kind of pick and choose their favorites. Mood disorders, I think we talked about yesterday, remembering that mood disorder is a big part of the menopause problem. That's where you should go with an oral estrogen as opposed to a transdermal. I also have to say, and I know I'm bouncing around a little bit and I apologize, but my patients very often don't want transdermals. They don't like having the patch, they don't like the feel of it. They're often complaining, even though that it shouldn't happen. They come off in the shower, they come off and they sweat. One of the tricks about the rings that you get that never go away is after you apply the patch, dust around it with some kind of powder, because that'll absorb the excess adhesives, and that's what picks up all that lint, is all the adhesive that's coming out around the edge. So I'm often giving people oral estrogens, and when I give oral estrogens, if they don't have a problem with the whole horse thing, then I still like giving them Premarin, for the main reason that I think a combination of lots of different estrogens and potentially a little androgenic activity is probably good for people versus a straight estradiol. But we'll talk about the bioidenticals in a little bit. Sexual dysfunction, for those of you who have heard me talk about that before, you know I also treat a lot of sexual dysfunction, and you probably still all know this slide. What are the classes of sexual dysfunction? The primary problems are decreased desire, decreased orgasm, decreased arousal. They all feed on each other. You have to identify which one is the primary source and aim to treat that one, but you can't remember the other ones as well. So if you have decreased desire, when you have sex, you're going to have less arousal. If you have less arousal, you can have painful sex. If you have painful sex, you have decreased desire. If you have decreased desire, you have decreased arousal. You're not going to have orgasm, so you have decreased. So you can see how you get into that cycle. So you need to make sure if you address one portion of the cycle, you address the other. Because if you stay in that cycle long enough, you can develop a sexual dysfunction, or you can develop vaginismus, which is, again, remember, tell people it's involuntary. It's very important they know it's involuntary. I just say it's your body trying to protect itself. If something hurts, what do? You do this to try to protect yourself. And you do that in the vagina long enough, you get spasm, and that's what vaginismus is. Hypoactive sexual desire disorder is the most common sexual dysfunction in most women of this age. It's often secondary to pain and decreased arousal and vulvovaginal atrophy, so you have to really make sure you treat that. You need to look for other causes, which can be lichen sclerosis or any of the lichens, vaginitis, the usual suspects. It may also be primary, and what I mean by primary is when you say to somebody, well, what happens when you have sex? well, I have sex, there's no pain, I had an orgasm, it's good, I enjoy it, but once I'm done, I don't care if I ever do it again. So that may be a primary, or you may think it's secondary, and it doesn't improve with treatment of the secondary causes. So what do we have for that? Basically a lot of counseling. We still have FLIBANSERIN, which has been out now for probably about 2 years. It acts centrally. It's not an on-demand drug. You have to take it every day. It was approved in 2015. It's only FDA approved for premenopausal patients. There is good data in postmenopausal patients that the company has not released. The reason they have not released it is because, one, they're not allowed because it's not the FDA approval. They will tell you about it, and I think they actually do release it because they give it out. But two, they didn't go for a postmenopausal indication because I think they were having so much trouble getting their premenopausal approval. They wanted to keep it for younger, healthier women. Do I give it in postmenopausal women? Yes, I do. I give it all the time. Do they take it? Very infrequently, and the problem is because it is expensive, okay? It's, again, FDA indication is desire. It's a daily dose. It increases sexually satisfying events by 0.5 to 1 event per month. Now that doesn't sound like a lot, but for a lot of women who have used it, it's the whole feeling about it that changes. So even if they're not having a lot more sex, they feel a lot more positive to the relationship. And I think, I always tell people, you know, having sex is like going to the gym sometimes. You don't really want to, but once you do it, you feel good. And the more you can get that good feeling, the more you're gonna wanna do it. So I think it can add on each other. Unfortunately, the biggest side effects is low blood pressure, which can lead to fainting. In order to prescribe it, you have to take a little test, which is like 4 really easy questions. It takes 2 minutes. It's not a big deal. Most of it is about the alcohol contraindication. They don't want people to drink and take it. Although I tell my patients having 1 drink and taking it, you're supposed to take it last thing at night before you go to bed because of the sleepiness. So unless you're waking up in the middle of the night and drinking, I don't see how it's a problem. But I do tell them if they are going to have a drink, make sure that they are not driving, that they are with somebody who they trust so that they're safe and they will have a way to be taken care of and taken home. I think what the fear is being in an unknown situation and fainting. Apparently, insurance coverage is also contraindicated. It's never going to be covered in your postmenopausal population because it's not FDA approved. It can cost up to $800 a month. Yeah, that's a very big drawback of it. The company plans on re-releasing it in probably about another, it should be coming up pretty soon. I haven't talked to them recently. It should be coming up pretty soon, and the reason is when you launch a new drug, you're apparently not allowed to advertise to the public for 18 months so that you can get more post-marketing data on side effects and risks and things like that. So as soon as they can advertise to the public, they're going to do a whole big launch again. Hopefully they will do something with the pricing. Hopefully there'll be some specials around that time. So maybe that's when we can get some drug out to some of these people. There are a couple other things in the pipeline that will hopefully come to fruition. Joint aches, again, if you're not getting relief with estrogen or estrogen-progestin combined and you really think that they're adequately treated and the timing was consistent with menopause, that's a good first line. Remember, people should be referred for a full evaluation. For other problems, you want to encourage, again, exercise, stretching, strengthening exercises in particular. Integrative medicine. This slide is purposely busy because that's what integrative medicine is, but I love the words that are in the definition. Healing-oriented, whole-person lifestyle, therapeutic relationship, evidence, use of everything. That's what integrative medicine is. I think many of us today have said we really want to work as teams, that this is not a I'm standing by myself kind of profession. Unfortunately, I think a lot of us are standing by themselves, and I actually felt much better after I researched some of this, thinking, okay, well maybe I'm not doing such a bad job, seeing as how I have a 15-minute appointment, and usually it's combined with an annual exam, and I'm trying to do it all on my own. There is something called healthy menopause, which the European Menopause and Andropause Society endorses, aimed towards quality of life and a less traditional model of healthcare provision, which again is looking for healthcare, health promotion, and empowerment of women. It's a model of healthy menopause and aging. I'm not going to do a whole lot. It's kind of more holistic, where they look at health and disease as a continuum, and they look at psychological, physiological, and societal. And healthy menopause, they say, is a dynamic state, and that's really important. So it's a dynamic state, you're continuing to grow and change, and we need to continue to recognize that. How they say it should work, this is a very busy slide, which I've broken down. You have a lead clinician and a specialist nurse. The specialist nurse is going to do the education, the physical activity, the diet, the stress management, the healthy lifestyle, and the prevention of disease. Okay, so there's one drawback right there, right? Because even though our nurses and our healthcare professionals are really good at that, we don't have the time to do that. We need to have active involvement by the woman who's going to recognize these short and mid and long-term goals and going to be an active participant. We don't often have that. We need a good referral system for physiotherapists, osteopathic medicine, chiropractors, naturopathy, homeopathy, Chinese medicine. We don't really have that. We need health care that's going to not only instate policies to help us, but give us money to help us. And we don't have that. So this is kind of what our goal should be. I don't know how we're going to do that unless some of the people who are younger with a lot more energy and a lot more vision can kind of pull this together. I know we screwed it up for you. Sorry, guys. Hopefully you can fix it despite us. Alternative therapies. Lifestyle changes. How much can we talk about lifestyle changes, right? We all know what we're supposed to do. My big one is ice water for hot flushes. Anybody who's having a lot of hot flushes who doesn't want to take anything should always have ice water with them. You know that whole brain freeze thing? It works really well for hot flushes. So if you're having hot flushes, have a Slurpee. I went to medical school, I did really. The other one, try to maintain sexual activity if that's possible, because the vagina, again, it's a dynamic organ, and if you continue to if it continues to have stimulation, it will continue to have good vasculature and healthy tissue. Cognitive behavioral therapy has been shown to be effective for most of the things that we talked about: hot flushes, sexual dysfunction, depression, sleep. We talked about that yesterday. Acupuncture, there have been 6 randomized controlled trials, and it has shown no benefits for hot flushes from either acupuncture or reflexology, although it is tremendously helpful for relaxation, joint aches and pains. We all know the kind of benefits of that. There are small studies that suggest clinical hypnosis significantly decreases hot flushes. Before I go to that, I actually went to a hypnotist because of my fear of flying. It was interfering with my career. It was interfering with everything. And there were just some times when I couldn't take a lot of Xanax and have 2 glasses of wine and get somewhere and be completely out of it. So I found a hypnotist, and this is really sad. I actually Googled hypnotist near me and found a guy who worked out of his house. Didn't have a fear of going to this strange guy's house to be hypnotized. And I left the address at home. I said, if I'm not back in 2 hours, send the cops. And it was a tremendous experience. This guy actually turned out, he had a lot of experience when they first started coming out with Valium, and this was kind of a little history trick for me. When Valium started coming out, you had to do it with therapy. You couldn't just take Valium. It had to be a whole process. And he had incorporated the whole hypnosis, and he had tapes. He actually gave me a tape, which I have no tape player to play it in, but he gave me a tape about the hypnosis, and it was wonderful. it wasn't like, you know, follow the ball, you're a chicken. It was kind of progressive relaxation, increased suggestibility, and he gave me just a strategy of, you know, this is how you're going to make yourself relax. This is what you're going to think when you relax, and it was really quite remarkable, to the point where I'm not even panicked right now that I have to fly again on Thursday, and all these storms we have are headed right up to New Jersey, where I'm flying into. I mean, normally I wouldn't even be able to say that without going into a full-blown panic attack. So it's something to remember that it's out there. Again, 3 sessions, lots of home exercises, and it really works. So just, again, when people are looking for alternatives, you know, it's good to have alternatives to offer them. Herbal therapies. I really wanted to talk about these because this is what our patients are doing. Perfect example, the woman with the bag from Mexico. There are some things that are good. Isoflavos, 35 to 150 milligrams daily. They had improvement about 20 to 30% above the effect of placebo. Now, if you remember, placebo effect is quite high, and even estrogen is only about 20 to 30% above placebo. So even though they're saying the average improvement is about 2/3 of that seen with estrogen, that's still a pretty good improvement. It's studied for up to 3 years of use. Soy kind of acts as a SERM. It's kind of a plant-based SERM. It has no evidence of breast, uterus, or thyroid effects. It does have some benefit on bone. And it actually exhibited life-prolonging effects in women with breast cancer, whether they were estrogen receptor positive or estrogen receptor negative. So it's acting probably on the estrogen receptors, but not turning them on in the way that estrogen would. The problem that people ask me, where do I get the phytoestrogens from? And that's where I think we run into a lot of the problems with the herbal therapies. I wish I had a good place to tell them to get the phytoestrogens. There are some cereals out there. There are some linseed-based cereals. There are some other cereals that you can get that amount of isoflavos from some of those cereals. People don't want to do that. They don't want to change their lifestyle. They don't want to incorporate tofu and soy and things like that into their diet. They want a pill. Right now, I don't think we have any pills we can reliably say contain what they say they contain. And that's the problem I have with all the herbal medicines. I would love to have a great Chinese pharmacy that I thought was really reliable and really had good quality assurance. I would love to use a lot of this stuff. I'm gonna jump ahead to some of the other herbal things, and this is the European level of evidence because most of the herbal information comes out of Europe. And again, I highlighted A, strong evidence of efficacy, and we should probably recommend it. B is good evidence of efficacy or likely effective, you could recommend it. C is unclear or conflicting and probably too little quality or quantity of evidence to recommend. D is fair evidence of efficacy, fair negative evidence of efficacy or evidence of ineffectiveness to discourage use. So when you look at the reviews of the other herbals, and this is particularly for menopausal symptoms, everything's coming up with a C, which is basically not enough evidence to really recommend it. The B is in the soy. There's also something I'll talk about in a minute called glycine max. And then black cohosh, which is coming in a B and C. I do recommend black cohosh to patients. I do recommend it by the brand name Ramifemin, just because Ramifemin has taken the time to do clinical trials. They do have pretty good safety and quality assurance studies. It has been studied for up to 6 months of use. It has been shown not to be interactive with other medications. And so I do recommend it. It works pretty well for hot flushes. The other thing that I find interesting is Dong Quai. Lots of people are looking for that for answers, and it's actually showing through the European studies, which are quite a lot, that it really is not effective, or it has been shown not to be effective. So I think the risk of taking something that is not effective or potentially effective can potentially be contaminated they found, just like the amphetamines in that, they find amphetamines, they find digitalis, they find lots of things. St. John's wort, which can give you serotonin syndrome, they can be quite dangerous. And again, I'm not saying that they're bad, I think they're probably great, I just wish I had better resources for them. I just did a review with one of my medical students about herbal therapies for sexual disorders, and when we looked it up, what kept coming up was ginkgo biloba and this Arginmax, which is a combination of ginseng, ginkgo, and a couple other things, including arginine. And so I asked her to not just look at the meta-analysis, but try to pull individual studies. And even though a lot of them didn't have a whole lot of significant side effects, I mean, the numbers, we have 68 women there, but it's only for 8 weeks. And in this one, they used placebo or sex therapy. So they didn't have the only one that had a good outcome was the ginkgo plus the sex therapy. When you looked at ginkgo alone versus placebo, it was no different. So they're not great studies. They're not a lot of studies. This one is 8 men, 4 women over 6 weeks. This one is, again, supplement or placebo. In the Arginmax, this is a medication that I looked at because a good friend of mine was diagnosed with breast cancer, and her breast surgeon recommended this when she complained of decreased sexual function. And she called me and asked me if I thought it was safe, and I looked it up and I said, I don't see a whole lot saying that it's not safe, but I don't see a whole lot saying that it's safe. And then her oncologist asked her to please not use it. So it's hard to go against what your oncologist is saying. So I think if you're gonna use something, you need to look at the data, but you also need to know where are people getting it from. And again, that's what ACOG basically is saying, is that there's no FDA-approved products, and since they're sold as food supplements, they don't have to adhere to FDA standards for content, purity, contamination, or consistency of dosage. It's pretty hard to recommend something like that. They're also often not placebo-controlled or blinded studies, and we don't have a lot of good data on what the interactions are with other medications. Weight loss, I think we've talked about that a lot. We need to talk to patients about, what's the new normal? You're not dieting and exercising to get back into a size 8. Unfortunately, it doesn't happen, but you need to diet and exercise to keep up your health. So again, the slide I put up yesterday that said I used to look good, now I look good for my age. I mean, it's a little bit ironic, but it's kind of true. And people have to be aware of that. The other thing is realistic expectations. When you tell somebody to lose 5% of their body fat, don't necessarily say 5%, depending on what you weigh, that's a lot. I know we might be looking for 10%, but when you have bariatric surgery, how much do you lose? It's about 18% or 19% in general. So without surgery, to tell somebody to lose 20 pounds, 20% of their body fat, tell them to start small. Say, I want you to aim for 5 pounds. When you hit 5, aim for another 5. Because if you look at it as I have to lose 50 pounds, that's a lot more daunting than let me try to lose 5. Again, avoid the fad diet, slow and steady. It's all about calories in and calories out. Drug therapies for weight loss, I'm going to skip these. I am not comfortable with them. I don't give them. You guys might. I just have them in there for completeness. I just want to touch base on 2 more things. Am I doing okay on time? 2 more things. Garcinia, which I know has been all over the news, right? Dr. Oz says it's good. The doctors say it's good. Everybody says it's good. Its active ingredient is hydroxycidic acid. There was a small study in Georgetown in 2005 that did show that people who got the hydroxycidic acid versus those who got placebo did have an increase in body weight and a decrease in body weight and BMI and a reduction in their cholesterol, their triglycerides, their leptin. They increased their HDLs. The people on placebos had a marginal or a negative effect. The bottom line was this is really interesting and compelling. The only problem is hydroxycidic acid was banned by the Food and Drug Administration in 2009 because of cases of hepatotoxicity. So it's not allowed to be in any FDA-approved supplements. So it's very hard to take it when it's in a bottle over the counter. Green tea extract, also interesting. Cochrane meta-analysis failed to demonstrate a significant benefit on weight loss or maintenance, but didn't separate it for caffeinated from non-caffeinated. So it's thought that the weight loss might actually be associated from the caffeine. This can also cause liver damage, and what's interesting is it works in tea, but not as a supplement. So it may just be either it's the caffeine, or if it's just the volume, you're just drinking more water, you're drinking more tea, you're full, you're eating less calories. Psyllium or fiber has lots of health benefits, and I don't think we should ever underestimate recommending psyllium to our patients or increasing their fiber content. I could not tease out if there was a difference between in your diet or as a supplement. Generally, healthier diets are always the better way to go, but I think supplements that increase fiber are probably also good. I just wanted to mention our cryolipolysis or fat freezing, right? You go in and they suck your belly into this little machine and then they freeze it, and then it slowly breaks down over time and your body reabsorbs it. The reason it works is because the fat is more susceptible to cold than the water-based, the water-rich tissue. So you kill the fat, but you don't kill the skin, or you don't actually cause damage to the overlying abdominal wall. There's been 450,000 performed thus far in this country without any significant side effects. The biggest side effect is a little bit of bruising and pain. The way that you get rid of the fat is through macrophages. They eventually kind of clear it up. There's no change in liver enzymes, lipids, lipid levels, or any blood parameters, so it's not like you're having this, all of a sudden, this fat embolus happening. It's expensive. It is FDA approved. The average reduction in the caliper measurement is 14 to 28%. So if you have a few $1,000 for the couple treatments, might not be a bad option. The other newer one is fat heating, which is Sculpture. I tried to find a lot of information about this. It is FDA cleared. It's a laser treatment. So the difference is they put a belt on you, and then you get lots of little laser stimulation to the fat. It basically works in the same way, but because they're not pulling you into a machine by a vacuum and freezing you, just putting on a belt is supposedly a more uniform application. At the last conference I was at, the Sculpture guys were there. This guy who was like 25 and weighed like 12 pounds told me he used it twice and it worked really well. They have in their brochures, and if you look online, they have lots of clinical papers written about it. They were all papers that were presented at meetings. I don't see any, I could not find any good published articles. It is FDA approved. It's certainly much newer, so I would probably wait till a little bit more comes out about it. Last but not least, I'm almost there, guys. Trying to cover everything. Bioidentical hormones. It's a misnomer, right? Bioidentical means identical to the hormones in our body. It does not mean natural, okay? Although natural does mean good, right? Let's look at some examples. Well, that's natural. All those are natural. Poison ivy is natural. And my favorite, cyanide, that's very natural. Okay, so natural doesn't mean good, and that's what patients need to realize. There are FDA-approved bioidentical hormones. Any estradiol product is bioidentical. Micronized oral progesterone is bioidentical. It's identical to the hormones in our body. Compounded hormones are not, they are bioidentical, but they're not natural. You don't pull the compounded hormone out of the yam and not do anything to it and put it on your body. You still have to chemically alter it to make it a bioidentical. Bioidenticals are not compounded. Compounded hormones are not FDA regulated. They have the same problems as the herbal medicines. They have an inherent variability as to dose, absorption, purity. They're not safer, and in fact, there's a lot less data on them, but people think they're safer. please don't check salivary hormone levels. There's no indication that they have any clinical utility. There is no indication that they correspond with blood levels. I have patients who come to me with like 16 pages of blood work. I had a person come to me with serotonin levels because her doctor thought she was depressed, so he took serotonin levels. I'm like, if it was normal, would you be less depressed? I don't understand that, but anyway. Endometrial protection may be at risk because you really don't know, especially with those progesterones, how much is being absorbed. Do I prescribe them? Sadly, yes. I have to confess that if the patient really insists on it, I know some of my partners will absolutely refuse, I will compound them. I will compound them up to the same dosage that the standard hormones are. I will do it only after a long discussion with the patient about how it pains me to do so. I only use 1 or 2 labs that I really know, or specialty pharmacies that I really know are compounding well. Sadly, Walgreens, you have Walgreens down here, right? Walgreens is everywhere. Walgreens used to compound, and I used to use the Walgreens in our hospital because I knew the pharmacist and I could talk to her personally, and Walgreens has just stopped compounding. I got a letter recently saying they're now farming that out to somewhere, so I have to look at that. More often, they will go see a naturopathic doc or somebody down the road, or just kind of pick something up. I feel like I spend a lot of time managing side effects and complications of the bioidenticals, and usually they're related to the bleeding profiles that come in. And I have seen a couple of hyperplasias. I have seen an endometrial cancer. Oh.
Questions?
You guys have gotten to my questions already. Okay, all the following are FDA approved for the treatment of the genital urinary syndrome of menopause, except. Right, Mona Lisa Touch and micronized vaginal progesterone. Which of the following statements about bioidenticals is true? They can only be compounded. Safety is improved by monitoring hormones. There are FDA-approved bioidentical estrogen products. So C is actually true. See, these are you guys who are getting bored listening to me talk and jumped ahead. See, you got the answer wrong because of it. The use of paroxetine for hot flushes should be avoided in, correct, the 54-year-old with breast cancer on tamoxifen, somebody with a history of breast cancer on no meds, it's not a problem. Based on available data, the safest is the patch and micronized progesterone. True or false, micronized progesterone has less negative impact on lipids than synthetic progesterone. True, again, it doesn't lower your HDLs. Thanks, guys, for hanging in. I know that was long.
We have time for 1 or 2.
Sure, go right ahead.
Oh, sorry.
Since we're concerned about the combination of progesterone and estrogen as far as breast cancer is concerned, and WHI said that there was a decreased risk of breast cancer in women who were on estrogen only. And then there was a recent article in the Menopause magazine that said that women, especially African American women, who had had hysterectomies, had a greater than 50% decreased risk of breast cancer. Do you think that maybe using the progesterone, the microprogesterone, more sporadically, i.e., maybe every 3 months, in ladies with a uterus, might decrease their risk? Just, there's no data that suggests that.
I think that's the problem, and I think about that all the time. You know, is less at a constant level better than sporadic? Are we doing something? I always wonder when we do things sporadically, are we upregulating, downregulating receptors? Could that maybe be worse? I think an alternative would be to just not give any progesterone at all and monitor the endometrium. We can do it with transvaginal ultrasound, you can do it with biopsy, and then even if you're getting thick or you need to treat, it would still be sporadic, but it wouldn't be ongoing. So I don't know that there's answers to that yet. And I'm not sure how the levonorgestrel IUDs are going to fit into that either, because that still has a little bit of absorption, although the absorption is so low that may turn out to be the safer way to go in women with a uterus. We just have to work on getting an FDA-approved indication for that, and that's gonna take a while, otherwise nobody in menopause is gonna have it paid for.